tuning in. I know you're right in the middle of your day, and I appreciate the time. Before we get started in this, I am doing this webinar from my home for a change, and there is a dog in the house, so if he sees a squirrel, he may make a little bit of noise, but we'll just let that go. So what I want to do is try and put something in this webinar for everyone. I realize that some of you are in rehab centers, some of you are with the VA, some of you are in private practices. There's opticians, there's technicians, there's doctors, and I've tried to put this together in a way that makes, that at least gives everybody something and makes sense to everybody. So regardless of your practice setting, that's my goal for today, give something to everybody. I always like to remind people that there's no right or wrong way to do a low vision examination. Some of you who are trained in a more formal setting, you have the idea that there's a certain protocol, but there's not. Do it the way that works best for you. I have discovered that there are some ways that tend to be slower than other ways, and this is certainly not meant as a jab to the schools, but when I got out of school, my low vision exams took about 2 hours. Seemed like 2 years at the time. Much of what I share with you today is based on my clinical experience. I used to tell people I'd been in practice for 30 years doing all low vision, which probably was 10 years ago when I was saying that. So I've been doing it a long time. But through Eschenbach, I've had the opportunity to travel around and meet with and discuss how very successful low vision practices are doing things. And it's amazing. We all tend to do things in a very similar way. Some of the things we do in a similar way, but it's totally different than the way we were taught in school. So here's the quiz. What does your low vision clinic and the Titanic have in common? And I've come to realize that our low vision clinics actually have a similarity. The people that got into a lifeboat before the ship sunk lived to see another day. And the people who get into your low vision clinic and you help function at a higher level are able to maintain their level of safety and independence. So, you know, keep that in mind. We're usually the last hope for many of these patients. I saw someone just this morning who actually started off in the retina clinic, and it turned out there was no retinal problem, ended up in the neuro-ophthalmology clinic, and while they did make a diagnosis, there was no way to fix the problem. What else do? You either send the patient on your way or end up in a low vision clinic. So keep that in mind. Don't ever get so discouraged on a bad day. Luckily, if you've listened to my seminars before, luckily there's only a few variables you have to manipulate when you're trying to help these patients. It's not really as complex as it may seem on the surface. And then regardless of your skill level, there's always additional help out here to help you grow your knowledge base. These webinars, that's one way, and I know that the Vision Expos and the various academies, there are continuing education things that could be helpful. So as I've talked to you folks at trade shows and things like that, and some of you have dropped me an email or so, these are the frustrations that I've heard. Number one is that it's too time consuming. And I get an email now and then, what's the code for an extended eye exam? Well, that tells me that you're spending a lot of time with these patients. The second thing is it's frustrating due to lack of success. And it may not be optical success, but functionally the patients aren't doing well. And then finally, economic issues. You know, if you're in a practice and you're trying to make low vision a center of the practice that makes economic sense, you can't really have the luxury of a couple of hour examinations. So my hope for today really is to just help you streamline the process. I'm going to share with you ideas that I've gathered from around the country and things that I do things. I want you to structure the treatment plan. You know, in so many other things, they are structured. For instance, you fit a contact lens, you take certain readings, you do diagnostic lenses. The next step is they go to the person training insertion removal, possibly follow-ups. And if you do these things, then the economic issues follow. So again, I told you I traveled around the country, and what surprised me is the large part of streamlining, what really saved a lot of time in these exams wasn't really in the exam room. These are just a few of the things I learned. these practices made sure the patient knew what I call the process. You know, what were the fees and the policies? How long were they going to be there? What to bring with them? All these things. So you didn't get the patient in there that had unrealistic expectations. They invariably, 100%, before they did one thing in the exam, they made sure that the patient had established realistic visual goals that could be achieved, and that they were concrete, so that you weren't searching around for this idea, I just want you to help me see better. They prioritized the goals, and you'll see why that was later on in the webinar, but they made sure that not only did they have realistic and established and concrete goals, but then they put them in order of importance for the patient. The testing was a lot different than than I thought. The testing in some of these situations was very, very brief. Some as simple as just getting those visual goals down, taking visual acuity, seeing what the visual acuity demand would be to reach that goal, and then finally maybe a brief over-refraction. Another thing that I noticed that I was just fascinated with is how much they would delegate authority to other people. Depending on who's actually doing the in-room clinical part, it's certainly reasonable to delegate a lot of the authority of doing other things in there, including training in the low vision aids, working the patient up, things like that. And then these practices all had someone that knew how to do what I call close the deal. I hate to use those salesman terms, but the ability to take all the clinical things and wrap that up and get the patient to understand what the next step was, which was leave with the low vision aids. So one of the practices that I loved the most had made one person in their team of their staff an expert. And for instance, the receptionist knew, let's see what's going on here. I got the battery low message. Not sure why. This could be terrible. And then someone that did pre-testing, low vision evaluation, etc. So based what I learned was, and I've said this to some of you before individually, was that initial patient contact. We like to use the idea of triaging or pre-qualifying every single patient. And what happens if you don't? You get into what I call circular discussions, where patient comes in, all I want to do is read the mail. And as you go through reading the mail, trying to solve that problem, then they say, well, you know what, this isn't going to help me with TV. So again, pre-qualifying. Then you don't get patients in that say, I've got a low vision aid like that at home. So the thing is, you want to develop a script and use it every time. This is a sample, and I've given this to Eschenbach if you want to take this and use it in your own practice. Phone rings, comprehensive eye care, Angie speaking, like to make a low vision appointment. Great, need a little bit of information. Who referred you? Dr. Jones from the Retina Center. Do you know what caused your vision loss? Macular degeneration. How long have you had the problem? Quite some time, guess 2 to 3 years, but it's gotten much worse. Can you still read? And this is a silly but revealing question. Can you still read your mail? Yes. No. Can I read the utility bill? No. Can I read the medicine bottles? No. Food packages? No. Can you read the headlines of the newspaper? Yes. So you know that that patient is worse than 20/50 because it takes about 20/50 acuity to do all those different things, except the headline of the paper. And they're better than 2400. These are actually great patients for most of you. Helping someone 20/50 to 21/20, every single practice in the United States ought to be doing those. And it gets a little more challenging 21/20 to 2200, but it can be done, and then a little more challenging beyond that. As Dr. Jones told you, there isn't a way to fix it, but with magnification, and again, we throw that in there so there's no magic glasses, can help you. Who's your insurance with? Because we want everybody to understand before they get in that there are financial issues in this and who's going to pay for what. We do this in a positive way. Medicare will pay for all your office visits, but unfortunately, none of the insurance companies pay for low vision aids. that we will need to use your help. In the area I'm in, VSP actually does, but that's still the statement we make. How much will they cost? We compare the cost of low vision aids to a pair of glasses. Based on our experience, they're going to be about the same. Oh, I thought my insurance would pay for this. No, and again, we compare it to glasses. As you know, Medicare doesn't pay for new glasses or low vision aids. And then you just really go ahead and make the appointment. I will also call you the day before the visit, answer your questions that may have come up, and we go on from there. Now, in years gone by, and I'm starting this again in 2017, I've actually been calling the patient and going over what's going to happen at the visit on that phone call the day before, because I want the patient to be darn sure that we're coming in with concrete visual goals, that the patient brings in any magnifiers, whether they help or not, glasses, things like that. Think about your office policies. That was another thing that struck me, was that there were no unknowns that the patient, they knew what they were getting into. For instance, refunds. What's your refund policy going to be on low vision aids if the patient decides that they're going to throw in the towel? Are you going to use loaners? I personally don't like that idea, but are you going to do it? If you are, then you need to think about what your policy will be on a security deposit for the loaner. You know yourself, if you decide to go to the rental store and rent a champagne fountain for a party, they don't just give it to you. They require both a security deposit and a rental fee. What are your charges and fees going to be? Most of us accept insurance, but there are practices out there that really we're charging fees outside of Medicare. Are you going to have a policy on no-show, last-minute cancellations? And, you know, the reason for that one is the amount of time. So here's a for instance. This is something we put in every time we dispense a low vision aid. They get this statement, and it says, you know, low vision aids should not be confused with cheap over-the-counter magnifiers. Prescription low vision aids are made with the same precision, and we're trying to educate the patient that this low vision aid that may cost them I hate to say a lot of money, but compared to an over-the-counter magnifier, I guess you'd say a lot of money. So again, I think that it's language that you might find helpful. Another thing is, and this is our policy, low vision aids are not returnable. We take great care in determining the best aid for your visual goals. Remember, a low vision aid is just a tool, and what I'm trying to do there is transfer some of the responsibility of using the tool to the patient. Your success with any low vision aid will require some effort on your part in order to learn to use the device properly. Now, do we ever give refunds? Sure we do. But if we have this statement, that kind of takes away that person who thinks, you know, I'll give this a half-hearted try, and if it doesn't work, I'll just get my money back. I really want people to invest not money so much as the effort. A statement that I make to patients all the time is, you know, if you take me to Home Depot or Lowe's and you buy me every tool in the place, I am not a carpenter. If somebody would teach me how to be a carpenter, the skills, I could probably be one. And the same thing with low vision aids. They're tools. We'll show you how to use it, but then you're going to have to go out and use it. So what's the next step? Got to confirm the appointment the day before. And I was telling you that I have gotten to the point where I'm starting to call people myself in hopes that I can actually streamline the process a little more. Repeat key portions of the script. For instance, visual goals. I want you to have written visual goals. Bring me samples of the kinds of things that you want to be able to do that you can't do. Because again, I don't want to spin my wheels trying to do these things when it could be done in advance. Normal registration at this point, ask for visual goals, and if they don't have them, then let's sit down and have the receptionist write them out for you. Must be specific. I have visual goals transcribed onto a 3x5 card with one goal on each card, and I'll show you why in a little bit. And then organize those cards before they go into the exam room by priority of the patient. place those with the exam materials, where most of us are on electronic medical records, so there's not so many exam materials. And then prior to the history, discuss, and again, prioritize those visual goals. So now we've gone from the receptionist to possibly a technician doing that. Remember, your history is always more functional than it is medical history. For most of us, it doesn't matter if they've had 10 Avastin injections for their macular degeneration as much as I can't read my mail and my bills and my food package. Then on eye charts, what's best for you? You know, this is the good old Feinblum chart. I use that. In fact, this is actually my one of my exam rooms. I've got it on an IV stand if you're looking for a creative way to have it and wheel it around. The good old EDTRS chart. It's great. It is a little bit bulky in terms of trying to tuck it into a corner, but it's sort of the gold standard. There are various types of near-point charts. These are single optotype chart, game charts, continuous text. And more recently, I've been using that chart that Jillian is going to give you guys, this easy reading chart, because of all this stuff that it's got in the middle. We put these out in our general eye clinic and use those as workup charts when we're trying to determine if the patient, you know, can read the telephone book and all these other things. So it's a pretty neat chart that you guys are getting. What about additional testing? You know, when I was in school, every single person had every single test known to man. And contrast sensitivity testing, well, every patient that has low vision has reduced contrast sensitivity. There are no exceptions. So does it help you to take the test? Does it tell you what sort of low vision aid to use? Not necessarily. So contrast sensitivity testing, in my opinion, is sort of a plus minus. I actually do use them to show patients and their families why this person doesn't function. Visual field testing, there are times when that may be helpful. Refraction is kind of tricky in low vision. You know, the analogy I use, and you'll probably see in this, is a good camera with a bad roll of film takes a bad picture. How much time and effort and energy on these geriatric patients you want to spend in refraction, I'll leave up to you. Patient workup, consultation and education begins the minute I step in that room, before any testing beyond entrance test. Based on pre-testing info, consider making an understandable statement of what you can do, how you do it, and for instance, when I walk in, I've got a patient and I know that they're 2100, let's say, and they've got 5 visual goals. I'll look over the visual goals and I will look at the patient and I'll say, Mrs. Jones, based on your visual acuity alone and what your goals are, I think that I'll be able to solve most of these problems, if not all, and it'll only take, and then I put a number in, 2, 3, 4, 5 low vision aids, so that in their mind now they've heard that there isn't like a Swiss Army knife for this that's going to take care of everything. Don't be afraid to bring the patient back to reality. I can't make it the way it used to be, you know, and then sometimes we can only make it less bad than it is. I said that to a gentleman yesterday. Unfortunately, I can't make it the way it used to be, but I can make it better, or at least take a bad situation and make it less bad. Examination, refraction. The gold standard is a trial frame refraction. I suggest if you are buying one, a set, buy full field lenses, because it allows eccentric fixation, finding the null point, things like that. You remember the concept of just noticeable difference? It's the lens increment that someone can respond to. And you know, in normal refraction, it's plus or minus a quarter diopter. As the acuity goes down, that just noticeable difference goes up. Any of you that want to know how to calculate it, if you'll shoot me an email, I'll go into that. But I've had flippers made up in plus and minus signs of equal powers. For instance, plus and minus a quarter, a half, 1, 2, 4, and you can use those to very rapidly see if a little tweak of their habitual prescription helps. So one of the things too, this last point on this page is, you know, how do you check for apparent changes in Rx to avoid what I call the bent wrist syndrome? And that is when the patient comes back holding their glasses in their hand with their wrist bent, saying these don't help. If a patient has a a small change in prescription. Maybe they pick up a couple letters on the next line of the chart or something like that, and you're getting ready to update that prescription. Be sure and have them compare their old power to their new power, looking at a human face. Human faces are so low in contrast that it'll really tell you. If they can see facial features better, the prescription will probably work. You know, you got to have some way to figure out what your near point, what your magnification is going to be. And there's all sorts of formulas that I can supply you with that you can find on the internet. Some of the test charts have suggestions. I believe this Easy Vision chart has suggestions on level of magnification. So where are we? We've made the appointment. We triage the patient. We've got visual goals. You have put them in order of priority. You know the best corrected level of vision, and hopefully you know the level of vision required to do their goals, because when you triage them, you told the patient to bring in examples and samples and things. You stated to the patient that magnification is what you're going to have, and it may require multiple aids. So then now this is where the 3x5 card comes in. I try and achieve the visual goals in the order of the patient's priority. I put that first card down and I work until I've achieved that goal. And if the patient tries to take me off task, where they'll say something like, yes, this will help with reading, but what about television? Well, let's get reading established before we go on to television. As I solve the particular problem, I take the low vision aid that helped with that problem, set it right on that 3x5 card. And then when you're finished, you have the appropriate low vision aid lined up in front of the patient based on their goals and their priority in an order that they should be able to understand. This is kind of what it looks like. So we're going from the top of the slide to the bottom. Wanted to be able to read hands-free. They had a trip and a fall. They wanted increased mobility, something quick that they could read the mail. They go to the theater and read the menu in a restaurant, and that's what it looks like. All right, where do we go from there? So after you gather information, then you've got to switch into the problem-solving mode. And this is just a couple statements before if you use support staff, you're going to turn it over to the support staff. From what you've told me, if I can help you read mail bills, food package, and control glare, this would be helpful to improve your independence. Is that right? Well, that's a loaded question. They're going to say, sure. As you summarize these goals, you actually physically pick up the aid and say, okay, so to read hands-free, this is what we found is going to be most helpful, and just go down the line. And then we transfer authority. We give it to somebody else. This is where support staff comes in if you're in a setting where you can use support staff. If you're in a general eye practice and you're wondering who that can be, very often a really helpful person is the person who's used to teaching contact lens insert removal. They tend to work very well. Or if you've got an optician or a dispenser. And then when we transfer authority, I always like to tell the patient or the client who this person is. You know, I'm going to have my technician Sheila work with you now. She's been working with me in the low vision department for a blank number of years. If you haven't had a low vision department for a long time, she's been, you know, working in the eye care field for a blank number of years. So they don't think that they were flipping hamburgers at McDonald's last week. And then at that point, staff takes over, and this is sort of like the features, benefits, and limitations. So patients, not just patients, all of us are in this what's in it for me mode. You know, why do I want to do this? And here's an example. Mrs. Smith, for reading your mail, we've both agreed that the best option for you is an illuminated stand magnifier. It has, and this is in the what's in it for me. Hang on, there it goes. Has a bright LED light, enclosed magnifier head. What this means to you is good illumination, enhanced contrast. It's got a great big switch, and it'll help with your arthritis. What this means to you, it's easy to turn on and turn off. A red reading line, what this means to you. So again, that's learning about the low vision aids and being able to present to the patient the what's in it for me. Don't take objections personally. You get to a certain point with a lot of these patients, and they have to think things through, and that's exactly what an objection is. Sometimes when we're talking about a more substantial amount of money, let's say a bioptic telescope or a inline video magnifier, patients got to think this thing through, and they need to justify their purchase. So this is how you kind of recap and restate how the products uh, would help the patient. You know, I always go back to visual goals. What do you want to do? And again, you told us that your #1 goal is reading hands-free. Well, there's 2 ways to do it: strong reading glasses and this video magnifier. And then based on what you told us, one of the things. Let me back up. I'm a sucker for what are called guided choices. And a guided choice is that you don't just throw it wide open. You narrow it down to A or B. My wife is great at this. Last night, do you want to take the garbage out before dinner or after dinner? It wasn't an option whether I was going to do this. And one of the things, sometimes when people seem confused, my staff will say, you know, this may be confusing. Today, do you just want to get the magnifier that helps you read, or the magnifier that helps you read and the tinted lenses that'll help with mobility? We often compare the cost of low vision aids to what the cost of new glasses would be, that we know won't help. You know, if it was simple as glasses, we'd all do that. Use terminology that differentiates low vision aids from cheap over-the-counter magnifiers. Boy, I didn't finish that one. Examples would be prescription low vision aids, medical low vision aids, things like that. So I'm getting close to the end, guys. Pre-qualify every patient. Please, please, please get in the habit of that. Otherwise, you're going to have patients come in, and as soon as they find out that the low vision aids aren't paid for by insurance, the visit's essentially over. Or the patient where you get them reading with a specific low vision aid and they say, I've got one just like that at home. Or the patient that says, after you get all done, you mean you can't fix my glasses? So again, that pre-qualify. You've got to have specific visual goals, otherwise you spin your wheels. It keeps people on track. I always use that analogy of a good camera and a bad roll of film. Guide the exam with your counseling. All testing has to solve problems, match goals with aids, manage objections. Prescribe, don't recommend. Learn everything you can about your aids, because that's going to speed things up. You're an eye care professional, not a banker. And like the rescue boat in the Titanic, you're the last hope. There is no plan B. So look in the mirror. What are you doing these days? What do you see? And thanks for spending some time with me today, everybody. Jillian, you there?
Great, yeah.